Good afternoon, friends. May I have my slides, please? Professor Vivek Saraswat, my opponent today, has been the person who has been a co-worker, a valued colleague for the maximum duration as compared to any other co-worker that I have had. Starting from 1980, Vivek, when I was a fifth-year MBBS student and you were a first-year MD resident, when you've taught me so much, to now. We have had these debates on a daily basis in our daily lives treating patients. But this is the first time that we are here together on a dais debating an issue, and it's apt that it's at our Karambhumi, SGBGI. So let me remind you, ladies and gentlemen, the last slide that Vivek had, more work needs to be done. So I think he's already said that it is not ready for domiciliary treatment. But let me say, my presentation still, though he has already conceded that there is need for more work. Next, please. Next slide, please. Okay. So I don't need to tell you, Dr. Saraswat has already told you everything. And I agree with him that the word domiciliary isn't clear in the proposition. Domiciliary to me means a relatively unsupervised therapy over a long period of time, and there I agree with him. But for that, it means the view about something is very clear. We think that it is ready for the prime time and possibly for everybody. And that I would try and convince you it is not. So let's see the studies. I'll not go as far back as that one study in 1948, but more reasonable past. The first time that people talked about doing treatment with albumin was this paper in 1999 from Italy, where they took patients with cirrhosis and ascites, where ascites was persisting despite bed rest and low salt diet, and they randomized them into diuretics or diuretic plus albumin in a somewhat low, at a dose of 12.5 gram per day to see whether it will control ascites. And after ascites was controlled, they randomized them to long-term 25 gram per week of albumin or just the diuretics. And they showed that there was a difference in ascites recurrence and hospitalization, with albumin group doing better, but there was no survival advantage. Remember, this was an open label study done in Florence, Italy from 1993 to 96. The next paper appeared quite late in 2006, again from Florence in Italy. And this was an overlapping period, 1993 to 2003. And we don't know if some patients were included in both the studies because this is from the same group. Here they gave them albumin, 25 gram per week for first 1 year, and then 25 gram every fortnight. And they showed that ascites recurrence rates were different, but this time there was no difference in mortality or survival. And then we come to the ANSWER trial that Dr. Saraswat has so beautifully explained to all of us. So what they found was there were a lot of benefits. Hospitalization was reduced. Complications of cirrhosis were reduced. There was a survival advantage. And what they found was serum albumin increased from an average of 3.1 and stayed stable in the group that did not get albumin and increased to about 4 in the group that got albumin. But remember, this was an open label study, again in Italy, in 31 centers. This study, though it's called ANSWER, actually raised many questions. Firstly, it was an open label study. One could argue that primary endpoint was death, which is not subjective. However, as and when a subject needed frequent large volume paracentesis, the person was censored from the study. And this could have been subjective, and that would alter the results, even if mortality is the endpoint of interest. Only about 1/3 of those screened were included in the study, and the rest were excluded. So it was doubtful whether the results of the study apply to all patients with cirrhosis, especially the excluded people who had complications other than ascites. Patients in the treated group had a weekly contact with the health system, with the doctors, with nurses. So if they had anything else, that would be picked up and they would be treated. The other group did not have that. If they had also met the doctor every week and not received albumin, we don't know what would have happened. Is it the frequent contact with the health system or is it albumin? We don't know. At that time, HCV treatment was not available. So maybe that would have been better rather than giving albumin. And the cost effectiveness analysis that they did not include indirect costs, travel to hospital to get the infusion, and the loss of wages. Then we had the next trial, the so-called MACHT trial. This took patients with cirrhosis, and they were treated, they were enrolled into a randomized placebo-controlled trial. Nearly half the patients getting midodrine and albumin, and the other group receiving placebo. That's the dose of midodrine, and albumin was given in a dose of 40 grams every fortnight, half of what was given in the ANSWER trial, and the outcome was a composite outcome of complications of cirrhosis. This was done in a different country, Spain. It was randomized, and for a change, this one was a double-blind study, which we would rely on more. They found that the probability of developing complications were similar in the group that received albumin and the one that did not. Mortality was also similar, though plasma renin activity and aldosterone activity were improved. Why were there different results? As has been said by Dr. Saraswat, the albumin dose here was lower. The serum albumin actually rose to only about 3.4 and increased not only in the group that received albumin, but equally well in the group that received placebo. And the duration was only about 80 days. And finally, we have the ATTIRE trial about which you heard earlier. These were patients who were hospitalized with decompensated cirrhosis with serum albumin less than 2.5, worse disease than what was included in the ANSWER trial. And they were randomized to standard treatment, with albumin being given if there was a standard indication, something like HRS or SVP, or targeted 20% albumin solution for 14 days or until discharge, so as to improve their albumin concentration. This group received on an average 20 grams of albumin during hospitalization. The other group received about 10-fold. And we can see that serum albumin improved in one group to about 3.2, but did not improve in the other group. This was done in the UK. This was again randomized and was open label, but large majority of patients here had alcoholic liver disease. And we find that composite endpoints were no different in the group that received large dose of albumin versus that received it only for specific indications. Also, as has been said by my opponent earlier, serious adverse events were more common in those who received albumin. So now let's look at these 5 studies. 3 in Italy, 1 in Spain, which was double-blind, and 1 in UK, the largest study. So these to me would carry more weight. Clinical events shown here in green showed improvement. Survival showed improvement in 2 studies. Adverse events remained neutral. But when we look at these 2 studies, which I would pay more attention to, there was no change in clinical events, there was no change in survival, and in 1 adverse events increased. So to me, these are much more reliable. This is a slide that you saw earlier. So let's look at ANSWER study as a representative of a positive study, MACHT study as a representative of the negative study. And we can see this was open label, this was double blind. The duration of treatment was different. The patients here in ANSWER study had milder disease and they had more severe disease, and the amount of albumin given per week was different. It's possible that, and here the albumin increased in the ANSWER study, but serum albumin did not change much in the MACHT study. So that's what you've seen earlier. So one can speculate that for albumin infusions to be benefit, we need to increase serum albumin to 4 grams. Increase has to be prolonged, and it has to be done in such a way that there are no adverse events. But most of our patients actually have serum albumin which is lower than what was seen in the ANSWER trial, and we may need to give a higher dose in terms of grams per week. Again, this speculation is something that remains to be tested. Now, so this article, from which Dr. Saraswat extensively quoted, actually ends with saying it would be unwise to propose long-term administration to all patients with ascites who can be quite different, and there are some patients who have relatively milder condition, they could possibly benefit. But they very interestingly point out, it should be acknowledged that Italy represents a sort of unicum with respect to other countries. Their health system pays for albumin, And they use albumin for many other conditions that the rest of the world does not. If you look at the usage of albumin per 1,000 population, in Italy, it is 601 gram. All developed countries, including UK, Germany, France, Canada, Japan, they use much less of albumin per 1,000 population. Even within Italy, in some provinces, the use is as little as 230 grams per 1,000 population to 1,200 grams per 1,000 population. So Italy is unusual. They have the Leaning Tower, they have Venice, they have pizzas, they eat pizzas, and they seem to drink albumin. If you look at what happens to albumin in Italy, so their demand is so high, they say, so this is something on consumption. Italy is the primary consumer of albumin in the world, and its domestic production covers only 60% of demand. And globally, it is thought that people should use 400 kilogram per million or 400 grams per 1,000 population of albumin, but they are using much more, and they are unable to produce adequately. Cost effectiveness, which Dr. Saraswat said we need to know. Let's look at this. Even if we ignore the initial loading dose needed, and we ignore the fact that our patients may need a higher dose, just think of 40 grams per week. I went to 2 or 3 websites that sell drugs in India. Cost of 20 grams is an average of 6,000 rupees. 40 grams, which we need to give every week, will be 12,000. Over a year, 52 weeks, 6,24,000. If we take the rate at which people die from the ANSWER trial in the group that receives albumin, average survival, the area under curve for this will be 4 years. That means a patient who's given albumin will spend about 25 lakhs in the period that he has to live. I think I would rather go for transplant than to go for infusions of albumin. I know organ shortage is a problem, but if I have that much money, then I would do that. As per global burden of disease study in 2017, we had about 85 lakh people at any time in India with cirrhosis. Today number may be higher. Remember, we all think as if albumin is something that's produced in the factory. No, it comes from human plasma. And 1 liter of plasma, companies can produce about 25 grams of albumin. To produce 40 grams of albumin, a weekly dose, we need 1.6 liters of plasma. To sustain a patient for a year, we need 83 liters of plasma, 400 to 500 blood donations. Even if we try to treat these 10% of these decompensated cirrhosis patients, we'll need 60 lakh liters of plasma a year in our country. Each donor unit gives us 150 to 200 ml. We'll need 3 to 4 crore additional units of blood donation in the country for preparing so much of plasma, so much of albumin. Our current donations, my dear friends, are 1.4 to 1.5 crores per year, and we are short of blood. So, in my opinion, it remains doubtful whether prolonged albumin therapy, sorry for that mistake there, actually works in patients with cirrhosis at best. As my worthy opponent said, it works in a select subset. It seems to work in Italy, not elsewhere. I suppose you have to eat pizzas with it for it to work, otherwise it does not work. Even if it works, it's too costly. We must appreciate that albumin is produced in a liver and not in a factory, and there are limited supplies worldwide. If we start using it like this, knowing the principles of economics, the prices would shoot up. Even if they don't, we need 83 liters of plasma for one person, 400 to 500 blood units for each person per year. So, in my opinion, domiciliary or long-term albumin therapy is not a valid option for management of cirrhosis, at least not in our country, in our setting. Thank you.